Sure to hit record. All right, welcome everyone to the DIS ECHO program. My name is Desiree Rested, and I'm the Training Development Manager with the Montana Public Health Training Center at the University of Montana. Our ECHO sessions are funded by the STD, HIV, and Hepatitis C section of the Montana Department of Public Health and Human Services. As usual, we would love to see you come off camera. Thank you, Mary Dale. We are always happy to see such beautiful and handsome faces join us, especially at the end when we have time for questions. In the meantime, if you have any questions during the session, please feel free to come off mute or to pop those into the chat. And Dr. Osborne-Wells always leaves enough time for us to have conversation along the way. So please look forward to that as well. Today, we are joined by the wonderful Dr. Mariska Osborne-Wells. She has worked with the Denver Prevention Training Center and the Disease Intervention Training Center for the last 5 years, adding to her passion for working with others who want to see continued innovation in STI, HIV prevention, and innovation. Dr. Osborne-Wells started her public health career long before working for an official public health entity. Her career began in geriatric care in a nursing home where she saw the impact of aging and disease on those around her. Dr. Osborne-Wells is a veteran of the armed forces, and while proud to have worn so many hats, there is so much more to do. And she chose to make a mark through sharing the knowledge she has gained with others. And we are very privileged to have her with us again today. So with that, I'm going to pass it to you.
Thank you so much. And I'm going to go ahead and share screen. If you can let me know when you see that.
Yep.
Awesome. So thank you all again for joining. This is session 3 of the 4 for the DIS ECHO series. And today we're actually going to start working through the stumbling blocks of client engagement. And since Des did such a great job of my introduction, I'm going to not bore you with the rest of those details. Our agenda so far, we have covered in session 1, normalizing difficult conversations. That was a dynamic conversation where you all were able to share what's been happening in where you're stumbling through the interviews and how we can navigate around that using our communication skills as well as MI. The second session, we introduced the STI HIV interviewing format. And the only thing I'm going to reiterate from that session, which was also recorded, is that if you want to use that format, it is not a structured script that you have to stick to. It is structured in a format that it is not linear. You can make it your own and implement any different pieces into your interview that you feel comfortable with. And then today we're actually going to work through a case scenario where I will introduce you all to Caleb Walker, and we're going to have some decisions to make on how to navigate Caleb's interview. The last session in 2 weeks will be the application. We're going to put together all of these things into role plays, and I hope to see all of you there because it's going to be our mistake zone. I want you to try something new, bring a new skill, and learn from each other. Our learning objectives for today, we're going to identify the behavioral, verbal, and nonverbal cues of withdrawing, recognizing common engagement obstacles, demonstrate techniques for checking in with the client, as well as with yourselves. We're going to identify topic areas that create hesitance during the interview. And lastly, I sent out a self-assessment for capacity to conduct an interview for the Montana staff that they will share with you all. It's not something that you have to do. It's just a general check-in. Where am I with my ability to go out and interview folks to the best of my ability? There's no wrong answers because sometimes we feel on, sometimes we feel off, but it's just assessing where you're at before you conduct your interviews. So as we dive in, I like to start with the withdrawal cues, because it's not something that people are made fully aware of as we're operating. When we're talking and hoping somebody hears us, but when we're in that listening capacity, folks, we're oftentimes listening to solve a problem, we're listening to respond. and we may miss things that are visual to us or that we may not be really paying attention to. So when I'm talking about the withdrawal cues with our clients, they get overwhelmed with the situations that we're presenting to them. I want y'all to think about when you approach a client, we're not approaching them just to see how they're doing at that moment. We're approaching them with news that can change their well-being in that moment, change the trajectory of their life, and possibly their relationships, right? So a lot is happening for that client, and we want you to be able to recognize what's happening for them. So I provided some examples. These are not exhaustive, but they are the most common that we would see when we're engaging with the client. Recognizing early behavioral signs. If I'm the one that's doing all the talking and they're just looking at me like I've grown another head or they're looking through me, they may have shut down and disengaged, but I want to be able to recognize that and call it into the space and let's talk through it. How do we get them back engaged? They may just avoid the conversation altogether and give you one word answers. Yep, nope, I don't know. And that's also that verbal cue, that short. Sorry, y'all. I just noticed I had a whole error on my typing. It's been a day. But they give you that short, chilly response that is just, I want you to shut up, stop talking to me. What do I need to do to get you out of my space type of responses. Or on the flip side, it may be, I'm so sorry. I'm so sorry. I don't know. I don't know. I can't answer that. I'm so sorry. That is also a buying time mechanism for some of our folks. It's okay. What would you need in this moment? How do we get you through that? The nonverbal, if I'm sitting here like this, the entire conversation, and I'm avoiding that eye contact, I might be finding a pen. I'm a fidgety person, so y'all will notice I talk a lot with my hands, but our clients will give us a lot of things to work with, but are we in the mood to recognize it? If I keep pushing back my chair, you're in my space, I want to stand up, I want to walk away. Those are all things that we need to be looking for. I would love for y'all in chat. What are some of the things that you've noticed, either behaviorally, verbally, or non-verbally with your clients that could tell you that they're shutting down from the conversation? What's coming to mind for you? Hey, Melanie, I saw you kick us off with checking the clock or their phone. Absolutely. The clock watchers are sometimes my favorite. You might want to pause. I see you're looking at the clock. Where is it that you need to be right now? And just check in with them. Tamina, please correct me if I say your name wrong. Looking at their phone. The phone now becomes more interesting than the conversation. Absolutely. What else have y'all noticed? Yep. Uh-huh. Okay. I love that. And I'm going to switch this up. When we're not with our clients, I want those of you with kids or teenagers, especially when your teenagers don't want to talk to you, they want to shut stuff down. What are some of the things you notice with your teenagers? Yeah. Gretchen, I saw you put in big sigh. If they went from super talkative to super quiet, absolutely. That is a huge tell. Because when they do that, you may have touched on a topic that they're like, whoa, this just got kind of personal. Okay, go ahead and keep putting those in chat. Give each other some responses, give some love when you see something you're like, yep, I've seen that. So here's how we can flip script just a little bit, right? Once we recognize it, what do we do with it? Because now, and Des, you're my girl. I'm going to invoke your name a little bit. If I'm interviewing Des and all of a sudden Des is like, giving me the big sighs, I'm interrupting Dez's whole day. She's got better things to do. What is it that I can do to respond if I'm not ready to call it out or put a name to it or try to figure out what's going on for the client? I need to pause and reassess everything that is going on. What was it that I just said that changed the trajectory of our conversation, right? What made Des possibly uncomfortable? And then once I'm thinking I have it, I want to re-implement or re-engage the client. And I can do this in a couple ways. And again, these are not exhaustive methods. All of you are going to have a different way of checking in with the client. But again, these are the most common that we've tested out in client interviews. So we're going to use that grounding question. I'm sensing that I'm making you a little uncomfortable right now. What would help you feel more comfortable as we continue? Just bringing it back to ground level and getting them re-engaged with me. Is it always going to work? Probably 70% of the time. So now I got to have something else in my toolbox. Normalizing the emotion. I sense that you're a little stressed right now. These questions can make you uncomfortable, but they are necessary. It's okay if this feels tough, right? But that's how I would say it. You would just put your own verbiage in there. Normalize what you're seeing, what you're hearing, and what they could potentially feeling. And I'm going to pause here just to say the client may not even have an issue. It just be their normal personality. But we're going to call attention to it, give them an opportunity to correct, and they'll be like, no, girl, I'm fine. Just do your job, ask your questions, right? So, but we want to be able to offer up that autonomy and empowerment for the client to be able to correct us. The next one we want to do is offer choices. If I'm moving too fast, let me know. I can slow down and take a little bit more time. Or if I'm moving too slow, let's change the topic right now. I sense that this topic, we're talking about your sexual partners, is making you a little uncomfortable. We are going to need to talk about them at some point, but we can move that towards the end of our conversation. How does that sound? And we're still giving them options and autonomy to drive the conversation. The next thing we want to do is reflect on it. And I gave y'all a couple examples as I was going through, and that's all it is. What I'm seeing, you're portraying, I'm giving you an opportunity to correct. Tell me if this is right. Tell me if this is wrong. Am I off the mark? What is it that we need to do? Lastly, if you were here, session 1, I think we talked a little bit about MI. If y'all have not taken any MI trainings, I highly encourage it because MI is highly focused on the person and how we're engaging with them to make sure they have empowered autonomy and they understand that the conversation is about them and how we continue having healthy sexual conversations with them and their partners. What questions come to mind for you all so far? We're going to pause before we go into problem solving. What are we thinking? And Christy, I saw your last comment. They won't look you in the eye. They are looking anywhere else. Absolutely. And I will say that could also be a cultural thing. So we may want to assess the cultural background for the person that we're also working with, right? So we're not going to assume, hey, I see you're not wanting to make eye contact with me. Tell me what's going on with you right now. How can I make you comfortable? How does that sound? Is anyone in the room with me? I'm not comfortable with DIS being so quiet. It feels weird, but I get it. We have some introverts, some extroverts. All right. So seeing none, hearing none I'm going to move on to introduce you all to some problem solving methodologies. In the packet that we shared out on the first session, you will see 2 acronyms. The first one is going to be CHART, and these acronyms, public health folks, we love a good acronym and they always got to mean something to me. So this one has been around for several decades, I think, for DIS training. Because when we're talking to the client and things kind of get off and they're like, well, I don't have to worry about this. I'm already treated. I'm okay. It's no problem, right? But no, we want to employ chart as a way to keep the conversation going, to motivate them into finding ways to notify their partners of the exposure, etc. So the first thing on our list is C for complications. When we talk about the complications, we want the client to know what are the complications of untreated or undiagnosed disease, right? So if we're thinking about undiagnosed gonorrhea, drop in chat or come off mute. What are some of the complications that we want to impress upon the client if they go untreated or their partners are untreated for gonorrhea? What are some of the complications that come to mind for y'all? And again, feel free to put in chat or come off mute and talk with me. Okay, I'm seeing infertility. Yes, childbirth, the complication. Oh, now y'all are talking. That can happen. Chronic pelvic pain, absolutely. PID. And on the flip, what about our males? What happens to the other gender? What are some of the things that are complicated? I'll give you a hint. The testes are impacted is one, as they also get that infertility. I hate to pass it along to some of our men, but yeah, it can happen. What else? Do we remember DGI? Epididymitis. That's the word I'm looking for, Tamina. Yes. And y'all, let me tell you, if you have never seen epididymitis in a client, it looks horrifically painful. So that could be a motivator in getting them to continue talking to you. Yes, painful urination. Fabulous. The next one is H. We want to talk about the HIV STI connection. The same way they got STI is potentially the same way they can get HIV. Asymptomatic is our next. I want to say the last percentage that I saw was about less than half, like 48% of the population. Don't quote me on that number. It's still early, but less than half of our population will actually have symptoms of STI and or HIV. So if someone says, I'm fine, I haven't felt anything, I don't need to get tested, but they're in that interview period, we may want to talk about the asymptomatic nature, right? Next, we want to talk about the reinfection. Put a one in chat if y'all have ever heard your client say, you know what, I'm not worried about it. I've been treated. I can't get this again. I'm immune. How many of us have heard that? Put a one in chat if you've heard that. Yes. A lot of folks will be under the impression that if I have syphilis or gonorrhea or chlamydia the first time, I got the treatment, I'm immune. I can no longer get it. So why are you telling me I got another exposure? We want to talk about the reinfection potential and how often it may happen for folks. And then lastly, the transmission. We want to impress upon them the methods of transmission for infection. We have a bunch of young folks right now that think if they're having oral sex only, that they're not at risk for anything. We all know in our business that's not true, right? So, anal, vaginal, oral, we want to talk about all the methods of transmission. And for our folks that are of pregnancy capacity, we want to also talk about the mother or person to child transmission as well, included in that. So that's our chart method. What questions do you all have on chart before I introduce you to my favorite lever? Oh, Tamina, yes, toys. I don't think we talk about toys enough. We don't give that enough of the conversation. So thank you for bringing that into the space. What questions do you all have on chart? Yeah, I'll talk more when we get to Caleb because he's fun. Okay, lover. This is another problem-solving methodology. So in the beginning, I talked about how we re-engage the client. I wanted to give this to you all as a, what do they call it? A mnemonic to remember, how can I engage with this person? First, I'm going to listen. What am I listening for? I'm listening for the verbal cues that identify that they're having some issues either with the conversation, with the information that I'm imparting, or are they having issues with providers? I'm going to listen for all of that. I'm also observing their behavior, their body language. Christy said they're avoiding eye contact. Am I observing some avoidance when they're not looking at me if I'm asking a direct question? So, taking those two things, I'm then going to validate it, right? Like, I sense, I feel what I heard you say, etc. So that's how I'm validating. I'm using either polite imperatives or my open-ended questions. I'm sensing, and Desiree, I'm going to use you again, my apologies. Des, I'm sensing that this conversation is not going the way that you thought it was going to go. What's happening for you right now? What are you thinking about? Who are you thinking about? Because it could be that they've already thought about this conversation and they may have someone in mind that they're concerned about telling. So I'm going to validate and check in. When I'm exploring, it's okay, let's talk about this. What is it that we can do? How can I fix this? Am I in a position to offer this client what they may need, or am I not? I'm just doing that internal exploration of how I can respond to what I'm seeing, what I'm hearing, or even what I'm not hearing, those nonverbal cues, right? So I'm doing that internal exploration. And when I come up with a response, it's like, okay, so Des, I'm sensing that you don't like the way I'm asking the questions. How would you feel if we changed the method of questioning? And let's talk and get to know you first. So that's going to be my response to what I'm seeing, what I'm hearing, and I have validated with the client. Does lover make sense, folks? What questions are coming up for you all? I see some thumbs up. Thank you. Thank you. And you, again, you have these in your packet. I would say employ them in your interview. Get comfortable with them because sometimes it helps to have a skill that you can go back on and you're like, oh, I remember this. I have to listen. And I can't listen to respond. I have to listen to the entire thing. Think about what I can offer either as an explanation, as a opportunity, a change before I say it out loud. Okay. And now I'm going to need some responses from you all because this is what we're here for. I would love to know what are some of the topic areas that may cause your interview slash conversation to stall? What have you come up against? And again, you can either come off mute or put it in chat for us. What areas do you find cause the most hesitance or stalling? Okay, Tamina, you're saying drug use. Can I put you on the spot if you're okay? Tell me what areas of drug use. Okay, perfect. Denies drug use. Okay, so how do we ask about if we know from their medical record, and Tamina, I'm going to change this up a little bit if you're okay with that. We've already done the medical record searches. We've seen the drug use, right? They've admitted to the provider what types of drug they use. But now we're asking these questions. We're somebody that they don't know. They haven't developed that trust that they have with their provider yet, right? They're going to worry. What are you going to do with that information? Are you going to call the cops on me? Am I going to have my kids taken away because I use drugs, etc.? So how do we put their minds at ease that these questions we ask of everyone, and they are just to help us with your care? That's it. How would you put that into a conversation? While y'all are thinking about that, Maria says when asking about how many partners they have had, yeah, or when asking who are your partners. Okay, so we have scripted versions and transitions, right? So for those of you that have been doing interviews a very long time, I know you're not doing it the same way every time. You're assessing your client, seeing how open you can be. And one of the biggest things that I still carry from when I learned DIS interviewing 15 some odd years ago was my transition statement set me up for success. I'm going to ask you some questions to get to know you and also to get to know about your partners, who they may be, and when the last person was. That's just setting up the big picture. And once we get into that finite detail, I have to have a why behind what I'm asking. So I don't want to ask questions just willy-nilly. I just want to practice asking the question first. Why am I asking this? So the client is going to be concerned about why do you need to know that? I have to be able to say, well, the same way you were able to come in and get tested and treated, we want to afford your partners that opportunity, getting them in the door and helping them navigate the systems if necessary. But we want to make sure that your partners are as healthy as you right now. One way to say it, it's not the be all end all, right? Um, I thought I saw another comment. Christina, patients saying they'll contact their partners, but not wanting to give us the information or providing only the name, who they thought exposed them. And Christina, my friend, that is like the holy grail of hesitance. I don't want to give you the information. I will take care of it. And we go back to this being a voluntary process. Yeah. But hey, you mentioned that you want to talk to your partners. Let's go through. How are you going to tell them? When are you going to tell them? And you start the conversation there. If they're like, well, I don't know how I'm going to tell them. Okay, I can give you the information that you're going to share with them. How about I give you my business card and they can also call me when they're ready to get tested and treated? And we can come up with a code that they can give me and I know who gave them my name. We're nothing if not flexible because, folks, when you do coaching well for that notification strategy, they'll probably end up being like, well, I didn't know I needed to give them all of that information. So here's who they are. And sometimes it's just a matter of time. You may not get one person the initial interview. You may get one on the second re-interview. You may get two on the third re-interview. But you want to keep that door open. If they're hesitant, cool. How can we get to notify your partners? Would you like to have me available? You have contract. If they want to talk to them first, let's share the information and I can talk to them after and make sure they got into the clinic. The clinic is going to need to know what they were exposed to. You have all sorts of things in your toolbox. It's just a matter of finding the comfort to pull that out and employ it with the client. Does that make sense? And I know y'all are making it sound super easy. It is easy until you sit in front of a client with an actual diagnosis. What other questions, concerns? Because now is the fun part. Hey, I heard this on our last session. So I figured I would title our next couple slides this. It's different when you know them, because I heard what you all said. In small towns, rural Montana, you're going to run into people that you know, right? Makes no difference, folks. They are still someone that can benefit from your services, and we're going to treat them with professionalism, confidentiality, and protected privacy. So let's meet Caleb. And you can read this. I will read this out loud. Our client is going to be Caleb Walker. The Montana DIS is scheduled to notify Caleb Walker of an exposure to 720 secondary syphilis. Caleb has been identified by a male partner that also disclosed versatile sex, oral and anal, no condom use. Sex occurred at a hotel 4 times over the last 6 months. The DIS recognized the name on the FR as someone they went to high school with. They also know that Caleb is married to a cisgender female. Unfortunately, big unfortunate, but we're going to make it work. Due to staffing shortages and several DIS knowing Caleb, there is no one to trade this case with. And this is an actual true scenario that could potentially happen from what I heard you all talk about in Montana when I was there. So it's never that easy, right? We have a twist. Because the DIS and Caleb know each other personally, this conversation has the potential to be heavy from the outset. Why is that? So, some of Caleb's fears are embarrassment and worry that the conversation will be used as gossip. Again, small town Montana, rural area. Is the nurse that checks me in, she's probably going to know me. Is she going to talk to the lady that runs the library down the street when they meet for coffee? And I'm exaggerating here a little bit, but this impacts the story. Second concern is that his wife is going to leave him. So we have potential loss of the relationship. Any anonymity that he may have had, because guess what? If Caleb tests positive, we now have to notify the wife. The wife has no confidentiality parameters for herself. So then it's going to get out there, right or wrong. Y'all went quiet again. So lastly, he gets angry that you're even contacting him. Why are you even here, Kayla? We never liked each other in high school. Why are you even here? You enjoy this, don't you? You want to see me fall. You want to see my relationship fail. It's gonna get into a hot mess. That could be what's happening for Caleb. My DIS, the folks that are doing the interviewing, you're in the field. What are some of the things that is happening for you as you're in front of Caleb, or even before you go meet Caleb? What's happening for you as the DIS? And you can come off mute, talk to me, or put it in chat. What are some of the things that you're feeling or going through? Discomfort of my staff who know him. Yeah, they're going to have that discomfort. They might not even want to go out there. And it's like, can't somebody else do it? Can't we wait? I don't even want to talk to him because it's giving me anxiety. What do I say to him? Or how do I look him in the face? Absolutely. He has every right to refuse, and most likely he will, right? Like, get off my lawn. I possibly would find someone else if there is friction from being small town Montana, maybe contact an outside health department for help. Michelle, thank you for bringing that in. That is also a consideration. Christy, a little anxious about the conversation. Yeah. Christy, can they come to their supervisor if they're feeling that anxious? What can supervisors do to assist the DIS at this point?
Yeah, Mariska. I mean, I think while we don't supervise the DIS, we have a slightly different relationship. Folks can always call if you need somebody to kind of talk it through with. You want to have a conversation ahead of time about how the conversation is going to go and what you could say. Um, Melissa, our nurse consultant, would be happy to talk to you and talk that through as well. So, or any of our staff really. So, yeah, absolutely.
I love it. So, folks, you have some options. And then Christina said some of the things she might be thinking about. Bleh, sorry. Where should I meet him or could I meet him without alerting the wife before he knows? Find someone else to interview him and let him know. The end game is to get him treated. Absolutely. My role here is not to judge, it's not to put you in a box, not to identify you as anything. I really just want you to know of the exposure so you can make some decisions on your end. So it's valid that the DIS are going to have their own hesitance in approaching Caleb and what to do next. So, of course, I'm going to hand y'all some cues. So, Caleb, he becomes a little quiet, shifting in his seat and stops responding fully. His verbal, he says to you, people don't need to know my business. And that includes you, Kayla. You just being nosy. You just want to tell everybody that you talked to me today. And I know it. Non-verbally, he's crossing his arms and he's just checked out. He's looking at the floor. So I would love for you all as the DIS, we're going to look now at how this encounter can play out because we have some decision trees, and I want to talk through this. So, our first decision is A. Do we push forward with explaining the test, the treatment, and what we do as partner services? Because our potential outcomes are Caleb will shut down, he wants you out of his face, tells you he will handle it himself. What would you all do in this situation A? Do we continue and push forward, handle the outcome, those cues? What are we doing in situation A? Tamina, I see, assure him of confidentiality, but also let him know the reality. His wife will obviously figure it out. Man, thank you for bringing that into the conversation because it's not unusual for the spouse to have access to either the phone, the mailbox, or email. So no matter how we try to do a notification without going out there first, there is a potential for that person to find out. And then I saw you added, advise we can be present when he discusses it with her or be the one to notify her. Absolutely. We want to give those options. We want to calm Caleb's nerves a little bit. My end goal is not to ruin your relationship because let's face it, you were the one that went out there and cheated on her, but we're not going to say that to Caleb, right? We're going to empower Caleb to make the good decision, protect his wife and any other partners. Michelle, I saw your response. Let me go back up. Sorry. Understand confidentiality, treatment for him to read. Yes, giving him the information, explaining that confidentiality. And I think HIPAA violation rules are still the same. The breach is like loss of employment, a fine, etc. I always used to express that to folks so they understand how seriously I take confidentiality. Telling the laws, Christina, yes, I'm bound by laws to keep this information private. This is a professional, not personal. Like whatever we had in high school, it's cool. That's not where we're at now. And Tamina, yes, we all thinking. Okay, so let's try decision B. So we want to pause, name what you're noticing with Caleb. I'm seeing some discomfort as you're talking with me. We can slow down if you'd like. The potential outcomes, he begins to look a little more relieved. You use your motivational interviewing techniques, assessing where he's at. What are the hangups? How can we move forward and get you tested and definitely treated? Because if he is 720 with exposures in the last 6 months, y'all, he's definitely going to need some treatment, right? And wife now becomes a priority and any other partners he may have had. And then The personal connection is used as a bridge instead of a barrier. How about that? Instead of it becoming a barrier, you know what? You know me. You know I take my job seriously. I'm not going to put you at risk in the community. I don't want anyone to know about this. We're going to try to control the narrative. I want to get you in, get you tested and treated. We can figure out how we can let your partners know after we take care of you. Okay. So thinking about decision B, what skills are you all employing either for engagement, re-engagement, or moving the conversation forward to get that test done and treatment done? What skills are you all employing at this point? And again, come off mute or put it in chat. I did give you a big hint with the MI techniques. What was in our MI techniques, folks? What are those skills? I feel like I need Alex Trebek music at this point. Yeah, we might have to have you do that next time, Kayla. Okay. The OEQs, do we remember what the OEQs were? We use them all the time in DIS. The open-ended questions. I think y'all have fallen off on me, but we want to use those MI skills. The open-ended questions, the affirmations, you're taking time to talk with me is great. I want to be able to help you. The the reflections, and then also summarizing what we're hearing. What were some of his concerns? His wife, his relationship is probably going to be the number one thing. Um, oh, yes, Tamina, OEQs, the open-ended questions. I got acronyms for everything. Stick with me. All right, so we're going to do a lot with the scenario. Reinforce confidentiality. We're going to reinforce privacy. If you are able to test in the field, and I can't remember if you all have which type of test you all are using, if it's single HIV blood draw for syphilis or you have the Chembio, the dual test. If you're able to test in the field, maybe go ahead. Yes, Chembio. Thank you. Provide the test. You know what, Caleb? I can go ahead and test you right here, right now. We can have a response. How ready would you be to hear your results? And we can go from there. So that is that skill of knowing what I have in my toolbox that I can employ with Caleb right then and there. Our last decision. So we want to empower Caleb to be in control of the conversation and address any hesitance he may have in talking to us. Potential outcomes, he shares privacy and judgment concerns, worries about the stability of his relationship. But you know what? The DIS is able to manage um, to maintain rapport and keep the conversation going. Again, going back to that skill. What do I need from Caleb right now? The first things first, we want to get him tested and referred in for that treatment. And here's where you can also take a different path, which would make more sense. If Caleb has a provider, send him directly to the provider because that way we don't have to wait for a test result and then do another referral for the treatment. If we have treatment and testing available in one package deal, let's go ahead and get Caleb into the provider. Okay, but I understand in some of your rural/frontier areas that may not always be feasible. So at least get the test, get that out of the way, and then we can go into treatment options. Next steps. We've gotten Caleb tested and treated, but you know what's going to happen? Caleb has a positive syphilis test. So all of this we're going to take into session 4 because we're going to interview Caleb in session 4 as our role play. This session was recorded, so you have all of this information. I will send out the PDF, so you will also have this. I encourage all of you to join us for session 4 as we continue on Caleb's journey, because now you have a positive test for Caleb. I will give you a titer when we come back in 2 weeks. We're going to interview Caleb all collectively. So in your groups, and I'm going to set this up now, you will be paired up. You all will interview Caleb as a DIS. So one person will play Caleb, one person will play the DIS. But the reason I'm doing this is you all have different skill sets, different methods of interviewing that you're going to bring to Caleb. So don't feel like, oh, why are we interviewing the same person? Y'all are going to have different focuses. I guarantee it. All right. So our takeaways from today, recognizing that withdrawal can happen at any point during your interview, but we have to be mindful of when it's happening, that we're able to address it. How do we call a name to it without minimizing? I think I've seen a couple videos now where a young lady is in the hospital and she's in a lot of pain and she's crying, but the nurse is minimizing her pain. Well, it can't be that bad. We gave you pain medicine 3 hours ago, so you're being hysterical. That's what I mean by I don't want us to minimize. If the client is having a reaction, we're going to go with that. What is it that you need right now? This is a difficult conversation to have. How can I help you? What is it that would make you comfortable? What can put you in a better mindset? Maintain the environment of client autonomy. It is their interview. We are there to dance and lead the client to an outcome that is okay for them. And then the last one, I want to just reemphasize the relationship that you are building with the client affects the community, and that is the intervention, folks. So the relationships we have with that person is the intervention. What questions, what concerns, or comments do you all have as we part today? And I know Des dropped in the evaluation link. Please share with them, was this helpful? What's missing? How can we do better with the upcoming echoes? And I'm not seeing any questions or comments. So April 23rd, we will be having role plays. I do hope to see you all then for this practice area. And Des, you all are going to send out the assessment, the self-assessment for folks. Okay, that's all I have. Y'all take care of yourselves and each other.